now that's the technical schedule. I'm trying to stay at home. Stay at home, sir. Tell him I gave you the day off.
All right, good morning. There we go again.
Sure, that's perfect.
Game on.
Also,
Fun and games. Oncology. All right, any questions from what we covered yesterday? MDS and myeloproliferative stuff. All right, so today we're going to jump into the leukemias. And leukemias for some people are a little bit hard to wrap their head around, because a lot of times when we think about cancer, we think about a solid mass, we think about a tumor. But what is a leukemia? Cancer of the blood, cancer of the blood cells. And again, kind of going back to what we define cancer, right? We're keeping this simple, because none of us are planning to be, well, maybe some of you are oncologists in the future. That won't be me. So how did we define cancer? So think of it as just think of it simple. Think of it as this two-step process. First step is the body produces an abnormal cell. You have some mutation that causes an abnormal cell. That's step one. Step two is now you have proliferation of that abnormal cell. Then you have a cancer. Let's keep it simple. Abnormal cell, proliferation of the abnormal cell. Right. What we talked about yesterday, we talked about a disease process, MDS, myelodysplastic syndrome. And some people look at that as a pre-leukemic phase. But one of the things we said, it can progress to AML, which is a true cancer. MDS, we said, is not really a cancer, but we can think of it as sort of the pre-cancer. I'm going to attempt to draw on the board again. It never ends well, but it's all I got, guys. Still haven't been able to get anybody to get me something that can write up front. All right, so let's kind of back up for a second. MDS. Let me pull up the slide so you guys can see what we're talking about. Just kind of keep this picture in mind as we talk about these disease processes, right? Because again, we're going to be talking about cancers of the blood. So in MDS, you have a normal cell, right? You're a hematopoietic stem cell. So somewhere up here produces a blast cell, right? Immature cell. Now, typically what happens is this cell in a normal human being will continue to go through a bunch of cell divisions till it gets to a fully mature cell. What's a fully mature cell can do? What's the function? Why do we want the cell to mature to that stage? Just depending on what the cell is. If it's an RBC, what's the job of the RBC? What's the job of a white blood cell? What's the job of platelet, right? So you need the cell to mature in order for it to do its function. That's a normal person. MDS, what happens is this cell, every now and then, kicks out a crazy looking cell, something that's not normal. It produces a blast cell that's not normal. It's not like this other cell. All right, so I got this funny blast cell that freezes and does not continue to mature. It stops right here. Okay? Is that cancer? No, it's stuck as a blast. Right? Not cancer. Right? Because there's no proliferation in that cell. So what happens again in MDS, this cell minding its own business, kicks out another normal cell that goes to maturity, kicks out another normal cell that's stuck. So where is this occurring in the body? Where is hematopoiesis occurring? Bone marrow. Right, so this is happening in your bone marrow. So all of a sudden now, you have a bunch of these abnormal cells that's stuck in that blast phase. So if I don't go on to produce an RBC, what do I become? If I'm not producing a lot of RBCs, I get anemic. If I'm not producing WBCs, how does that show up? Infection. If I'm not producing platelets, how does that show up? Right? So that's MDS. And the number one in MDS that we saw was anemia. So MDS pre-leukemic phase. Today we're going to talk about leukemia. So in general, what happens with leukemia is I had this one mutation that produced this one abnormal cell. And then somewhere along the line, a second mutation hits that cell. And that second mutation now causes that cell to replicate like crazy, to proliferate. So now I get a bunch of these abnormal cells in the bone marrow. Now think of the bone marrow, small confined space. Eventually, all these abnormal cells are going to compete for resources, nutrients, growth factors, and it's going to crowd out these other cells. Okay? Just kind of keep that process in your brain as we talk about the leukemias today. Anybody completely lost? Everybody good? Ish. All right. Let's see. So again, cancer, all right, two-step process. You have a genetic mutation that produces that abnormal cell. You get proliferation of that abnormal cell. MDS can be seen as that pre-leukemic phase. It's that first step where I have an abnormal cell, but I don't proliferate. Keep this in mind as we work through this today. All right, leukemia, malignancy of hematopoietic stem cells. Excessive production of abnormal cells, right? The definition of cancer. I have an excessive production and I have an abnormal cell. Cancer. Classification, acute. Again, anytime you hear acute, think rapid onset. Acute phase, greater than 20% blast. So when you hear acute, think rapid onset, think immature cell. And the immature cell that we're typically talking about are blast cells. Chronic, think gradual onset. Some of these CLL patients can persist for years, right? So gradual onset. We're thinking about more mature cells. So something other than a blast. When we talk about the chronic, again, insidious, gradual onset, and you're thinking about more mature cell forms. And then lymphoid versus myeloid, all right? Whichever cell line we're talking about. Okay, acute myelogenous leukemia. What do you know about that disease process already? It's acute. Is it a rapid onset or is it a gradual onset?
Rapid.
What cell line is it?
Myeloid.
Myeloid cell line, myelogenous. Right. Acute lymphoblastic leukemia. What do you know?
Rapid onset.
Rapid onset. What cell line? What are you going to see? What's going to show up on that peripheral smear? What do you see in any of the acute?
Blast.
Blasts. Greater than 20% blasts. So if you get a CBC and you have a differential on that CBC and you're seeing greater than 20% blasts, then you're probably dealing with a leukemia. All right. Chronic myelogenous leukemia. Again, insidious onset, chronic, myeloid versus lymphoid. Here you expect to see less than 20% blast by definition. And typically what you're dealing with though is a more mature form. So a cell that's progressed further along the maturation phase. Epidemiology, yep. Okay, so ALL, most common in children. So pay attention to what disorder affects which population. AML and CLL, typically adults, as we'll see. ALL associated with kids. Kids and cancer, not a nice combo. All right, acute leukemias. Acute myeloid, again, older. Acute lymphoblastic leukemia, more common in children. Interferes with production of your WBC, your RBCs, and your platelets. So you have enough proliferation of something that myelogenous line, it's acute myeloid, and eventually whatever that is starts to crowd out the rest of the bone marrow, so the production of the other cellular elements start to decrease. Pathways. Proliferation of myeloid precursors. Failure to mature, acute myeloid. Right? That failure to mature that we saw in MDS, they're stuck in that blast phase. Well, now I'm producing a lot of them. Everybody good? Anybody completely stone cold lost right now? Don't want to say it. All right, I believe you. Characterized, accumulation of this. All right, so these abnormal blast cells. Myeloid, yep, bone marrow, got it. Our rods. We're going to see a picture of our rods. Our rods are pathognomonic for AML. Again, if you receive a differential in your future, in real life or in testing, and somebody says that there's our rods there, that should tip you off and you should start thinking about AML. Our rods, impaired production of the normal blood cells, yes, leading to anemia and thrombocytopenia. Sorry guys, this is all I got. So, bone marrow, cross-section of that bone marrow. All right, you got WBCs in there, right? You got your blast cells, you got your platelets, you got some RBCs. As these abnormal blast cells take over the bone marrow, I have less room to produce everything else. If it's interfering with my ability to produce RBCs, what do I end up with? If I can't produce enough platelets, what do I end up with? Yeah, right, so that's what's happening. So on these patients, we'll talk about what do you expect their WBC count to be? So they're producing a bunch of those blast cells. Yeah, so that's a kind of a trick question a little bit, right? Because it depends on what phase you caught this patient in. Early on, a lot of those white cells, right, are in the bone marrow. So they're white cell in the periphery, right? And the peripheral blood might look normal because they're all accumulated in the bone marrow. Eventually, over time, right, these will start to, so it might start normal, and then as these blasts stuck in the bone marrow, they don't mature. So what happens to the count in the peripheral blood? It decreases, right? Because they're all here and they're not growing. They're not becoming fully mature WBCs. Eventually, over time, what happens though is these blast cells spill out of the bone marrow, and now you start to see a bunch of blast cells in the peripheral circulation, and your WBC count goes up. Right? So early on, might be normal, and then it might actually decrease because you're not producing mature cells, and everything is sequestered in the bone marrow. Over time, that's going to get crazy, and it's going to spill out of the bone marrow, and your white count can spike. The problem is, even though your white count is up there, are those cells any good? Can they do their job? Can immature cells do their job? No. Right? So the white count might be elevated, but they could still be prone to infection. They could still have a neutropenia because they don't have a mature white cell. Good? Everybody good? I see some confusion on some faces, right? All right, we're gonna keep hitting this. AML. So again, anemia, because the WBCs, those blast cells are crowding out the bone marrow, so I'm not producing enough RBCs, I'm not producing enough platelets. AML, most common. Most common acute leukemia in adults, 80% of the cases. Median age 68. Again, cancer, a bunch of series of somatic mutations that take place over time, so more likely to see it in elderly. Risk factors, prior chemotherapy and radiation, exposure to certain chemicals. So, exposure to chemo and radiation, what do we treat cancer with sometimes? Chemo and radiation. So sometimes, are we treating a cancer and then we're setting somebody up for another cancer down the road?
Yes.
Yeah. So again, no treatment is benign, especially when you start thinking about chemo and radiation. Because what does chemo and radiation do? What does it affect that leads to cancer? The DNA. Right. Environmental toxins, benzene is one that we've known about for years. What do we call things that stimulate cancer? Carcinogens, right? Genetic predisposition, Down syndrome. What's Down syndrome? Trisomy of 21. So normally you have 2 genes, right? 21. Trisomy, you have a third, you have an extra gene. So one of the thought processes why we see a lot of ALL and Down syndrome is they think that additional gene as a marker has the ability to produce a protein that actually affects DNA. So a normal person has 2, not such a big deal. That third gene produced just enough more of this protein that affects DNA that you end up with ALL. So that's why it's one of the thoughts behind Down syndrome and ALL. That additional gene producing some more of that protein that's affecting DNA. All right. AML. You can kind of see the age distribution here. Males predominant over females, but again, elderly, 60s. Right? Now I'm calling 60s elderly. It's over. All right. AML. How do they present? Some sort of cytopenia. Right? And then you guys know what happens with these cytopenias. If it's anemia, you know this, fatigue, weakness, pallor. If it's a thrombocytopenia, is there a bleeding issue? Is there a petechiae and purpura associated with it? And then neutropenia, recurrent infections. Right? Everybody can kind of grasp that in their brain. Special features. So monocytic variants produce this gum hypertrophy, and then hepatosplenomegaly in some cases. So typical symptoms are related to whatever cytopenia they're exhibited, and could be all of the above. Lab findings, we said this, anemia, thrombocytopenia. The WBC count, again, could be variable just depending on where they are in that disease process. Is it so early in the disease that their white count still appears normal? Is it at a time where everything is sequestered in the bone marrow and the white count starts to drop because none of the mature cells are getting into circulation? Or is it a time where not everything is spilled out into circulation and that white count spikes, even though those are a bunch of blast cells, so they're not functional? Peripheral smear, by definition, myeloblasts, right? We're talking about AML greater than 20%. That's your cutoff number. 20% blast, cancer. Our rods, we talked about pathognomonic. Hypercellular bone marrow. Again, how does that compare to an aplastic anemia case? What does the bone marrow look like there? Hypocellular. Here, you can see all that reproduction, all that cell division in the bone marrow, crowding out the bone marrow, so my bone marrow looks crowded, it looks hypercellular. Elevated uric acid, where's that coming from? So again, this is a high proliferative state. You have a lot of cell turnover. You're making cells, the body's breaking down cells. Part of what DNA is that uric acid component of the DNA. purines and all that wonderful pyridines start breaking down, byproduct is uric acid. So these patients can have an elevated uric acid level. Don't get bent out of shape with the cytogenetics and flow cytometry. That's just kind of there. Again, cancers become very specialized. You can do special markers and special genetic testing and flow cytometry to identify these cells, which help target treatments. We primary care, Yahoo, don't need to worry about that stuff. Right? All right, power rods. These cytoplasmic inclusions that show up in these cells. Again, the primary care PA, are never going to be staring into the microscope looking for that stuff, but some lab tech will be. And if they note that and that comes back in on your differential, you got to be worried. That just ramped up your whole worry factor. That's pathognomonic for AML. More cytogenetic stuff, immunophenotyping. Again, just highly specialized testing to figure out what's what, so you can target treatments towards it. Treatment. Don't get bent out of shape out of treatment, unless I tell you to. Hey, so these are just some of the induction therapies that they'll start with. Consolidation, so a bunch of cancer-fighting drugs. Tumor lysis syndrome we'll talk about when we talk about the emergencies associated with this. But tumor lysis is ultimately you have a rupture of a bunch of these cells and everything pours out into your system. And no bueno, right? APL we'll talk about specifically because that's an easy one. Prognosis, yeah, variable, right? 5-year survival, better outcomes in younger patients. What's considered younger? 68, so younger than 68, right? Got it. But a lot also depends on, the cytogenetics of it. Because some of these diseases are more aggressive than others. AML, WHO classification, yep, got it. Again, don't lose sleep over that stuff. AML, so a couple different versions of AML. Depending on where that gene mutation took place. Here we're talking about, this is a translocation, the first one. Translocation, chromosome 8 and 21, more frequent in kids, sure. APL, acute promyelocytic leukemia. Talk about that one for a second, and then these are just some other, again, depending on where that genetic mutation took place. So APL accounts for 5 to 20% cases. Infiltration of the bone marrow by promyelocytes. What's a promyelocyte? Up to now, we kind of said, hey, these were all blast cells. What's a promyelocyte? Exactly. So if you go down that chart again, that diagram with the cells, just when you get from a blast, you go promyelocyte, myelocyte, metamyelocyte. So that promyelocyte is a little bit more mature than a blast, but it's still not close to being a fully mature cell. Acute promyelocytic leukemia. So the problem here is the promyelocyte. It's not the true blast. It's the next step in cellular maturation. The reason why this one also becomes important, besides how common it is this. So these cells contain this procoagulant substance that sets these patients up for coagulopathies and can lead to DIC. So I got this cancer patient, but in the DIC bleeding all over me. Bad day. The other nice thing about this one, there's such a nice thing when you're talking about cancer. What's retinoic acid? Vitamin A. So fairly readily treatable with a fairly benign treatment of vitamin A. So APL, acute promyelocytic leukemia, is that stage in maturation just beyond the blast. Again, there's your myeloblast, there's your promyelocyte. So a lot closer to being immature and is immature than you would say closer to the mature. So it exhibits symptoms consistent with an acute myelogenous leukemia. Okay. Any questions on that? All right. Therapy related. We talked about this a little bit in the sense that we said, hey, radiation, chemo can sometimes lead to cancer. Aggressive. Occurs months, years after chemo radiation. So a bunch of different chemo radiation type drugs. Again, you're treating patients, somebody treating patients, there's no such thing as a benign treatment. But somewhere down the road, we may be setting this patient up for another cancer. AML. Any questions on your AML? So again, acute, myelogenous, right? Blast cells is the key. All right. Moving on, ALL. What's the patient population we see this in most commonly? Kids. Pathophys, kind of same, right? In this case, it's transformation of those lymphoid cells. So what's the cell type that we expect to see if we peeked into this patient's bone marrow with ALL? What's your predominant cell type? Lymphoblasts. All right. Proliferation and cumulative blast cells, yes. Again, same kind of pathophys as the AML, except now it's being caused by the lymphoid cell line. It's the lymphoblast. But if this lymphoblast proliferates inside the bone marrow and starts to crowd everything else out, I start producing less RBCs, I become anemic. Less platelets, I get thrombocytopenia. I'm not producing my neutrophils. I become neutropenic. Sets me up for recurrent infections. Everybody tracking? All right, lymphoblasts. So sometimes these lymphoblasts can accumulate elsewhere. Meninges, gonads, thymus, all over. Genetic mutation, yeah. Hey, everybody forget that Philadelphia chromosome for now. That's a very specialized case. Just forget that unless we're talking about CML. Don't fall into that trap. So just put a star, cross it out, do whatever you do, but ignore that for now. All right. ALL. Again, most common in children, 2 to 5, 20% of adult leukemias, ALL. Clinical presentation. We said it's acute, so acute, we know that the presentation, it's a abrupt onset. And the same symptoms we saw before, right? You have a bone marrow issue, you got bone marrow failure, what do we got going on? The patient becomes anemic. You know how your anemia patient presents. Fatigue, weakness, tired, whatever. The pallor, right? Thrombocytopenia, yes. Neutropenia, yes. So lymphadenopathy, B cells. And when we talk about lymphomas, which are kind of an extension of CLL, right? Your B cells and your T cells go out into circulation and then they go to the spleen, go to the thymus of their T cells, go to your lymph nodes to fully mature and get storage. So you get this lymphadenopathy. CNS involvement, right? Kind of going back to here, we said that these lymphoblasts can accumulate in certain places, including the meninges. So I could have some CNS involvement. Now I have all these abnormal blast cells and the meninges. Bone pain. So common with these disorders, again, think of the bone marrow, this confined space, you got all these cells producing. Eventually these abnormal cells start to infiltrate into the bone marrow. That can cause a lot of pain for these patients, and it's not like in a localized spot, right? It's all over. CBC findings. What do we expect to see on our CBC? What's our CBC gonna look like? So so the anemic, because we're crowding out the bone marrow again. We're crowding out the bone marrow, I'm not producing my platelets. And again, just depends on where you are in the disease process, can kind of dictate what that white count looks like. But in these patients, a lot of times they're going to be neutropenic regardless, because even if that white count seems elevated, I'm producing blast cells, particularly in an acute lymphocytic leukemia, because what I've done is I've crowd out that myelogenous line, so I'm not producing my RBCs, I'm not producing my platelets, I'm not producing my neutrophils. Peripheral smear. What cell are we looking for if we're dealing with acute lymphoblastic leukemia? Lymphoblast. Bone marrow, again, hypercellular by definition greater than 20%. Elevated uric acid, elevated LDH. You know why the uric acid? And as it turns out, cancer cells, abnormal cells, seem to have this overproduction of LDH. Again, don't get bent out of shape over this cytogenetics, but these markers, they're important to help identify the cell. This way, you can figure out exactly what the cell is. So what does a blast look like under a microscope? A blast looks like a blast, looks like a blast. It's hard to differentiate it. They all look like whatever. So that a lot of the specialized testing is geared towards identifying what that cell is. Additional considerations. CNS, we talked about the meninges. So you gotta be worried that, hey, if this patient was diagnosed with ALL, if some of that blast cells, some of those abnormal cells end up in the CNS system. Examination requires what? If you're worried about the CNS, worried about the meninges, you need to do what on this patient? They're gonna need a spinal tap, you're gonna need a lumbar puncture. So you gotta look at the CSF to go figuring out, hey, did those cells make it there? They have abnormal cells now in the meninges, now in their CSF. Requires lumbar puncture. Got it. Failure to discover CNS involvement may lead to meningeal sequestration. So if they don't do this, and now they got this cancer looming in there, chance of reoccurrence or chance of badness down the road, landed in target treatment towards the CSF. Right. In general, this treatments, we talk about induction, consolidation, yes. So here, CNS prophylaxis. Don't worry about that. Stem cell, sure. Prognosis, 90% cure rate in children. It's pretty good. Any questions on ALL? Acute, insidious onset, acute, immature cell, and then just follow that through as those cells proliferate. What else am I going to see? What's happening in that bone marrow? What's it doing to the other cell lines? Again, AML, median age 68, older population, male over female, and by definition, it's a myelogenous line, so these are your myeloid precursors. So this is all your cells that can be affected. Peripheral smear, you expect to see myeloblasts, yes. And then pathognomonic for AML is the Irons. As opposed to ALL, which we see in children. I think the other slide said ages 2 to 5, this one says 3 to 7. You see a kid with cancer on your test who's 8. Right? You may have cancer, ALL, right? So don't get caught up in that. Just understand it's a disease of kids. Lymphoid precursors, yes. Peripheral smear, lymphoblasts. Make sense? Again, when in doubt, go back to the words. Words have meaning. Myelogenous line, you know what are your myeloid cells. Lymphoblastic, you know what are your ALL. You don't have much choice, right? ALL, lymphoblasts, blasts, AML. And the only reason you can really point these two out, one being different in terms of blast, is by looking at this. What are those? RODs. All right. Moving on. Got through the acute stuff. Let's hit the chronic. We talked about CML a little bit yesterday, or a lot, right? Under the myeloproliferative disorders. So again, myeloproliferative, big deal with CML is that translocation of chromosome 9 and 22, producing that Philadelphia chromosome. And what does that Philadelphia chromosome do? It turns on tyrosine kinase. What is tyrosine kinase? I see where this is going. All right. So these tyrosine kinase is that on switch. Tell cell to divide, tell cell to mature, to replicate. Philadelphia chromosome. All right. CML. Got it. So uncontrolled production of the maturing granulocytes. Chronic. When you hear chronic, again, think slow onset, think mature cells. And we talked about, hey, it's a triphasic, so the chronic, 80 to 90% of your patients are going to present in that chronic phase. And things start to go south, but then they accelerated, you start to see more blast. And then when you have more than 20% blast, you're into sort of that blast crisis. Age, older, 55, got it. And your cancer symptoms, right? B symptoms. When you guys, do your patient intake, and you're doing your review of symptoms, you're asking your fever, chills, night sweats, weight loss, all of that stuff. What are you screening for with all that stuff? Anything, everything, right? Potential cancers. Splenomegaly, yes. Accelerated. So once that starts to accelerate and you get more and more blast, that's a bad sign. That's the disease worse. Then you start to get the symptoms kind of consistent with an acute leukemia. CBC, marked leukocytosis. So somewhere usually 50 to 200-ish. So there you go, 100,000. Bone marrow, hypercellular. You have to do PCR testing to figure out that Philadelphia chromosome. Right, so specialized PCR testing. And we said what this gene does, the Philadelphia chromosome, is it turns on this tyrosine kinase, which tells the cell, go forth and divide, multiply. So your treatment, tyrosine kinase inhibitor. Prognosis, excellent with TKI therapy. Everybody good. Chronic myelogenous leukemia, chronic slow onset, myelogenous. What are your myeloid cells? All right. So chronic, they tend to be asymptomatic. Your CBC, yeah, all over the place. Right? The accelerated phase, they start to become more symptomatic. They have 10% blast-ish. So what's normal blast? If you get a differential black and you see some blast cells on there, what would be normal?
2 to 3.
Yeah, so most often 0, but if you see 2 to 3% on there, still in that normal range, and you start to get above that, you gotta be worried. Right. And then once you kind of hit that greater than 20% with CML, now you're looking at, hey, this is almost like an acute disorder. All right, CLL, chronic lymphocytic leukemia. Onset, fast or slow? What cell line am I dealing with? So what do I expect to see in my bone marrow? What do I expect to see in my peripheral smear? What do I expect to see? So in the acute, we said we saw what? Blasts. In the chronic phase, we're seeing mature cells. So you would see a bunch of normal-ish, right? Because these cells aren't normal by definition, but you're going to see more, something closer to a lymphocyte, a fully mature cell. Anytime you're dealing with chronic, think mature cell. Definition: bonal proliferation of mature B cell, B lymphocytes. Right. Uncontrolled production, yes, it's cancer. Got it. Indolent disease, slow growing. And we'll talk about Hodgkin's and non-Hodgkin's lymphomas because there's really a progression, the lymphomas, of this condition here, of a chronic lymphocytic leukemia. Most common in adults. Most common leukemia in adults, over 70, family history, yes, tendencies, right? So again, part of your screening, right, history, clinical presentation, CLL, often asymptomatic, incidental finding on your CBC. So again, as you there in clinic, drowning, seeing your 20 patients a day, skipping lunch, staying late to get caught up on notes, now you're reviewing a bunch of labs from 2 weeks ago, and you see something not right on a CBC, do you take the time to go look that patient up? Do you take the time to look at all the labs? Or do you like click, yep, good, and move on? Particularly because a lot of these patients are asymptomatic. Right? It's about doing your due diligence. And trust me, there are days where it's a grind. I like seeing patients, I honestly do. But there are days where it's a grind. And you have to be careful, and you don't get to take that day off and say, well, I'll get to that lab another time. Don't do that, right? That's bad for you, it's bad for your patients. All right, asymptomatic, incidental finding. What are our typical classic cancer symptoms? Right, our B symptoms: fatigue, weight loss, night sweats, lymphadenopathy. These are lymphocytes. Where do lymphocytes go to live? Lymph nodes. Right, so you get some lymphadenopathy. Splenomegaly, recurrent infections due to the hypogammaglobulinemia. All right, somebody talk me through that one. What's going on here? Good. What cell are we talking about right now? What cell are we talking about? This condition here. Let's go back to the beginning. What cell are we talking about? Lymphocytes. B lymphocytes. What's the job of a B lymphocyte? Plasma cell. What is it? What's the job of the plasma cell? Produce antibodies. These cells are close to being normal, close to being mature. So they're trying to do what a normal mature cell would do. So they're trying to produce antibodies. But guess what? These cells aren't normal. So sometimes they can't produce enough antibodies. They're not normal cells. They think they are. They're trying their best to act like they're normal, fully mature, grown cell, right? But they're not. So you can get some hypogammaglobulinemia because they can't produce enough. Or what's even worse sometimes is this. The next thing on there, immune hemolytic anemia. What's going on there? Positive Coombs test. I like it. What's going on here? So what's happening there is, again, these cells think they're grown. They're trying to act like they're grown. They're producing antibodies, but they're abnormal. They're abnormal cells, so they produce abnormal antibodies. And these antibodies turn on your own RBCs. And now you have an immune hemolytic process. Right? Because these cancer cells, trying their best, thinking they're normal, and what plasma cells do, producing antibodies, the antibodies are abnormal. And sometimes they can even result in an immune hemolytic process. Everybody good? All right. CBC, leukocytosis, got it. Hallmark of CLL, isolated lymphocytosis. Cytopenias may be present. Peripheral smear. So again, we said that these cells are not normal. One of the things about these cells is they're more fragile than a normal lymphocyte. Smudge cells. I got one lab tech in here, but they're the modern type of lab tech, so we won't mess with them. I'm the old school lab tech where we did everything by hand. So when you make a peripheral smear, we used to put a drop on a slide, we take another smear and we slide it across that drop of blood across the slide. What happens is, because these cells are abnormal and they're more fragile, they break apart a little bit. And instead of appearing like a normal lymphocyte, they appear like that. They appear as a smudge cells. So again, as you're going through your differential, as you're looking at that WBC differential from your CBC, if that lab tech said, you know what, I saw smudge cells on there, you need to be worried. Right? Because these abnormal, these cancer cells, they're more fragile than the normal cell, and they create this smudge cell on a peripheral smear. Associated with CLL. Yep, flow cytometry. So again, these are just a bunch of markers, right? Highly specialized tests to identify type of cancer, what cell is causing it, because that way you can target treatments towards that. That's all you need to know to really worry about that. Same with immunophenotyping, so bone marrow, yes. I guess, again, it's going to be an increase, it's going to be a hypercellular bone marrow. We don't have this overproduction of lymphocytes. Everybody good with everything on that slide-ish? Sure. Treatment. If they're asymptomatic, right, observation is okay with these patients. That all require treatment. Now, if you somehow have a patient that you think has CLL, and you say, oh, it's asymptomatic, I'm just going to watch him, is that how you're going to treat that patient? What are you doing with that patient? Refer. Right? You need to go see the specialist. Let them figure out, does he need treatment or not? Let somebody manage this patient. I'll be like, yeah, I'm just going to observe this dude for a while, see what happens. All right. Symptomatic, targeted therapies, yes. Treatment with chemotherapeutic agents, sure. All right. Complications, this Richter transformation, we'll talk about a little bit more in a second. All right. Perfect. Next, Richter transformation. I like it. All right. So what we have here is an isolated lymph node, right, transformed into this diffuse B-cell lymphoma. So what happens is these abnormal cancer cells, these abnormal lymphocytes, like to go certain places, right? Lymph nodes, spleen, whatever. Richter transformation is while they're in the lymph node, they undergo these other transformations. Right? So these cells have already gone through a series of genetic mutations just to be a cancer cell. Now they're in that lymph node, they continue to go through some more changes. And just think of it as it makes these cells more sticky, if you would. Right? So what happens is you end up forming a mass. So you go from this straight up cancer in the blood to now I have this mass in the lymph node. And they tend to be very aggressive. That's the Richter transformation. Right. Cancer cells end up in the lymph node, undergo some more transformations, and they produce a mass. Sudden clinical deterioration, rapid development of B symptoms, rapid progressive lymphadenopathy, increased LDH, anemia, thrombocytopenia. Everybody can kind of figure out why we end up with the anemia and thrombocytopenia. All right. Treatment, again, don't sweat the treatment type of stuff on these. Just understand your acute versus your chronic. How do these patients present? What cell lines are involved? What do they present with? Any questions on leukemia?
All right, take 10 minutes and we'll do the lymphomas.
Would tap out and get somebody else to come in. They would never wake anybody else up. They would just stay there the whole friggin' night, right? And everybody else just froze to death. Yeah. Good times. You too can live your life. Good times ahead for all of you, right? All right, so we talked about all the leukemias this morning. Cancer of the blood cells. The last one that we covered was CLL, chronic lymphocytic leukemia. And you can sort of think of the lymphomas as a progression of that chronic lymphocytic leukemia. Because what happens is those lymphocytes, those abnormal cells, end up end up in your lymph nodes. If they're T cells, where do T cells go to mature? Thymus. Right? And then you end up with a mass. So kind of think of it like that. But the two big categories we're going to talk about is Hodgkin's and non-Hodgkin's. All right. Yep, there you go. Distinguish between non-Hodgkin's and Hodgkin's. Lymphomas. Cancers originate from the lymphatic system. Got it. Transformation, B cells, T cells, affecting the nodes and other lymphatic tissues. Two types, Hodgkin's, non-Hodgkin's. So these are also like board type questions, is Hodgkin's stuff. Hodgkin's associated with this Reed-Sternberg cells. In your future life, when you're taking the pants, you see Reed-Sternberg cells, that should bring to mind one thing and one thing only, Hodgkin's. Non-Hodgkin's, by definition, no Reed-Sternberg cells. Non-Hodgkin's, more common, 85% of the cases, non-Hodgkin's. Hodgkin's has this bimodal distribution. So you'll see it early on, when I say early, young, 15 to 35, and then you'll get a second spike older than 55. Non-Hodgkin's. Hodgkin's and non-Hodgkin's. All right. Yep, I like it. Good. So what are we talking about, right? We're talking about lymphocytes. Talking about B cells, T cells, natural killer cells. Talking about these plasma cells. So you have these malignant cells that end up in the lymph nodes. Right. What was that transformation we talked about? Richter transformation. Okay. So you had these abnormal cells that ended up in lymph nodes and underwent some more changes and had that Richter transformation. All right. Non-Hodgkin's, yep. No Reed-Sternberg, got it. All right. Definition. Non-Hodgkin's lymphoma. Malignant lymphoid neoplasms, B or T cells, can be very aggressive. 85% of the time, this is a B cell problem. So more often than not, it's the B cells that's causing the problem. Diffuse large B cell lymphoma. That Richter transformation would result in a diffuse large B cell lymphoma. Right, these are aggressive. These are just some other ones. Follicular, right, more indolent. Burkitt's we'll talk about specifically, and then Malt we'll talk about specifically. But again, subtypes of non-Hodgkin's. Chromosomal translocations, here we go again. Right? Dysregulation of oncogenes. What's an oncogene? Turn it on. Right? So again, you have a dysregulation of the oncogene. Immunosuppression, chronic inflammation, yes. So all of that can contribute and lead you down the pathway to a non-Hodgkin's. multifactorial chronic inflammation, Sjogren's rheumatoid. Like, all those patients always make me a little bit nervous because those diseases tend to have some other badness associated with them all the time, right? All this autoimmune stuff. Chronic infections, we've seen this before, and then certain chemical exposures. All can contribute, right, to a non-Hodgkin's. Median age, 67. Like all the other cancers we talked about, right? CLL. CLL was a disease of young or old. Old. Cancers in general, right? We said disease of the elderly because it takes time for those mutations to take place. Increased risk with age, yes. Got it. All right, non-Hodgkin's, indolent, slow-growing, painless lymphadenopathy, waxing and waning. When I say waxing and waning, what am I referring to? Waxing and waning. Symptoms of waxing and waning. They're coming and going. Okay. So you have a patient who has this painless lymphadenopathy, who goes in the system or calls and says, hey, I want to go see my PCM, which happens to be you. And they say, sure, come in about 3 months, we got an appointment for you. By the time they get there, they're like, yeah, the symptoms aren't really there. What do you do with that patient? It's like, you take your car to the mechanic and whatever noise it was making, it isn't making it anymore, right? But don't get fooled by that, right? Get a good history, get some labs, try to figure out what's going on. Just don't say, oh, it's resolved, you're good. Right? Be careful. B symptoms, you guys know these. Fevers, night sweats, weight loss. Uncommon early, right? That's the more indolent forms of the disease versus the more aggressive, rapidly enlarging lymph nodes. B symptoms. Extranodal involvement and symptoms of tumor lysis syndrome. Physical findings, lymphadenopathy, right? So firm, mobile lymph nodes, and hepatosplenomegaly in some advanced cases. So these patients, and when I say rapidly, it can be like a couple of days rapid. When I was in Djibouti, I was passing through my clinic, I was there for a little bit, whatever. Brought in this army kid who's like, yeah, I have this thing on my neck that you could spot from across the room. It was like, yeah, like a week ago it was nothing, and then woke up and like it was like this huge thing across his neck. I was like, yeah, this isn't good, right? Ended up sending him to Germany, ended up coming back with non-Hodgkin's. On that deployment, even though I was only in Djibouti, right, for a couple months, here and there, like a week or two at a time, I ended up with 2 non-Hodgkin's cases, right? So you'll see this sometimes, just dumb luck. Non-Hodgkin's, excisional biopsy. So how are you going to make this diagnosis? Excisional biopsy. Again, these immunochemistries, right? CD20 for B cells. Again, these are markers. Don't wrap your head and try to memorize which marker to what cell. We'll leave that to somebody else to worry about. All right, additional workup. So what can you do if you're working up a patient? All right, where do you want to start? So the patient comes in, he's describing these B symptoms for you. They're like, uh-oh, now what? So basic stuff, right? Listen, at least get a CBC on this guy. Figure out what's going on. What do we expect to see? Anemia, thrombocytopenia, leukopenia, or lymphocytosis. So again, if we go back to kind of where we were with that CLL picture, the anemia, thrombocytopenia, everything is being crowded out, and then the lymphocytosis. Peripheral blood smear, lymphocytes, lymphocytosis. And then the chemistries, LFTs, LDH, uric acid. Why the uric acid? All right, we talked about it a couple times, right? And then LDH, these cancer cells seem to have a higher amount of LDH than normal cells. Imaging, PET scans. We're looking for extranodal involvement with non-Hodgkin's. Has it gone outside of the lymph nodes? Indolent observation, rituximab, don't lose your mind on the CHOP. All right. Again, I don't expect you guys to be able to treat cancer per se. Stem cell and CAR therapy. All right. Treatment, chemo, immuno, radiation, transplant. Prognosis. More indolent forms, long survival, often curable. The aggressive, potentially curable, 5-year survival. A big difference. Right. And going back to those subtypes, right, we saw some of them more aggressive, like the diffuse large B cells, and then some of them were more indolent. One of the subtypes, Burkitt's. Highly aggressive, yes, oncogene, and the subtypes, endemic, linked to EBV, Epstein-Barr, sporadic, more Western countries, and then HIV/AIDS immunodeficient patients, Burkitt's lymphoma. Rapidly growing, primarily affecting your B cells, B cell lymphoma. So the classic presentation in that endemic night. And we'll see a picture of it here in a second. But that jaw or facial bone swelling. So with non-Hodgkin's, the ability for this extranodal involvement. Jaw, bone, sporadic, the abdominal mass. Symptoms, pain, bowel obstruction, yes, anything you can associate with that abdominal mass. And then immunodeficiency subtypes, so it even gets more. Lymphadenopathy, the B symptoms, can have some CNS involvement. And there's the classic picture of that endemic Burkitt's lymphoma, right? Sub-Saharan Africa. So not something we expect to see here in the US, but we all wear the uniform, and we all end up in odd countries that we didn't plan to go to. Most common pediatric cancer in Sub-Saharan Africa. Primary involvement, again, these extranodal sites, mandible, maxilla, may spread to the bone or the meninges, associated with EBV, Epstein-Barr virus exposure. Endemic Burkitt's. Sporadic, associated with that abdominal mass. Pain, bowel obstruction, everything. Not doing anything. Swear. Burkitt's lymphoma, endemic, sporadic. Patient, pertinent labs, yep, CT, MRI, so PET scan, right? Again, what we're looking for is, hey, is this spread outside of the lymph nodes? One, what lymph nodes did it hit, and has it gone elsewhere? Pathology, tissue biopsy, sure, blood test, LDH, got it, peripheral smear, may show blast. Treatment, yep, some shorter, chemo, yada, yada, yada. Right. More stuff, monoclonal antibody stuff. Supportive. Hydration. Allopurinol. And we'll talk about tumor lysis later, but what is it that allopurinol targeting? Uric acid. Highly curable, yes. Greater than 90% outcome, yeah. So, and CNS involvement, right? Anytime you have a delayed diagnosis or you get CNS involvement, likelihood of badness increases. Hospitalization, yep, got it. Burkitt's lymphoma. All right, more non-Hodgkin's, more extranodal involvement. This is MALT, mucosa-associated lymphoid tissue. Path is low-grade, indolent, non-Hodgkin's. Opposed to Burkitt's, which is more aggressive. So here we have the association of H. pylori and gastric malt. And hey, these autoimmune conditions, again, they just rear their ugly head all the time. And what do we say what do we associate H. pylori with? Like GERD type symptoms. So these patients with H. pylori puts them at risk. Malt. Right. Non-gastric mucosal lymphoid tissue, same there. All right. Clinical presentation, often asymptomatic. But, hey, are they showing the signs, right? Dyspepsia, epigastric pain. Are they having those GI type symptoms? Rarely GI bleeding or obstruction. Extranodal involvement. Salivary glands, sure, like Sjogren's. So again, this is a non-Hodgkin's lymphoma that's presented in an extranodal fashion outside of the lymph node. How are we going to make the diagnosis? What are we going to do? Endoscopy, right? We're going to need to do biopsy. Again, a bunch of immunochemistries that you don't need to worry about. And then PET scans, CTs for staging. Treatment, H. pylori, treat the underlying cause. Right? Said it again, treat the underlying cause. If you can eradicate the H. pylori, most of these patients do okay. In some cases, though, we go back to a good old-fashioned radiation and chemo. Prognosis, yep, the H. pylori successful, it was excellent. Disposition, outpatient management, got it. Mucosa-associated lymphoid tissue. Non-Hodgkin's. Staging. Lugano classification. Yes, awesome. Hey. Presence of these symptoms does not have independent, got it, there. Let's talk about Lugano for a second. So 1, 2, 3, 4, and kind of depending on what nodes are involved, how many where. All right. So one node, yep, got it. Now I got 2 or more nodes on the same side of the diaphragm in stage 2. Nodes on both sides of the diaphragm, I'm in stage 3. Additional non-contiguous nodes, and we'll show that in a picture later on, with 4. So, which nodes, where, what side of the diaphragm? Lugano classification. International Prognostic Index, so yeah, risk factors, right? So again, older, age greater than 60, elevated LDH, stage 3 or stage 4. I've got more than one extranodal site. We'll talk about that for a second. Hey, so it just kind of depends, right? How many risk factors kind of tells you how bad off they are. 0 risk factors, 80% cure rate. 4 or more risk factors, drop to a 50% cure rate. Okay, so this next thing, East End Cooperative Oncology Group. I just threw this in here, don't try to memorize this. Right? But this kind of goes down levels of disability based on the severity of the disease. And I always like number 5, right? They're dead. I don't know what else to do with them at that stage. PET scans. So you use this for help staging. And this is bad, right? You can see before therapy, all the involvement, all the lymph nodes, right? All up in the neck, arms, axilla, into the pelvis, that are involved. And then after therapy, starts to improve. Before therapy, after therapy. Here it is a lighting up, right? Pre-chemo, that's bad. So chemo works. There's on the PET scan. Evidence of improvement. Non-Hodgkin's. Role of primary care, yes. Suspect, get some initial labs, maybe order some biopsy testing, and then refer. Yeah, not something that we want to try to manage in our clinic. Non-Hodgkin's lymphoma. All right, moving on. Hodgkin's. B lymphocytes. B cells. These world famous Reed-Sternberg cells that they would see on the biopsy. Let you know that you're dealing with a Hodgkin's. Classic Hodgkin's lymphoma. Right. So you got a couple of types. The classic one, 95%, so we're going to focus on that one. But you have this other creature here, the nodular lymphocytic predominant. Yeah. It's only 5% of the cases. Common things being common, we're going to stick with the classic. So we mentioned this, it has a bimodal distribution. You see this early on, teens to early 30s, and then again another spike above 55, associated with an EVV. So some familial stuff here, same-sex semblance, 10 times greater. Again, part of your job is getting that good history on the patient. They don't tell you something, sometimes you have to go and dig it out of them. You have to elicit the information. So a patient that you're kind of going down that road, you might start to get into family history a little bit more. Infection, we mentioned EBV, HIV. Painless lymphadenopathy. Often cervical, mediastinal, yes, arise from a single, a tendency to arise with a single lymph node and then spread to a contiguous lymph node. When we say contiguous, what are we talking about?
Connecting.
Right, so following that chain. Right? So you would expect to kind of see, like, if it's in the neck, maybe then into the axilla or whatever, versus jumping from here down to your groin. Contiguous lymph spread. B symptoms, fever, drenching night sweats, unintentional weight loss, pruritus, and alcohol-induced lymph node pain. So again, that's something specific to Hodgkin's. That itching, alcohol. Physical findings. To the lymph nodes, so yep, firm rubbery lymph nodes, often cervical, supraclavicular, and then potentially some splenomegaly. Non-Hodgkin's, Hodgkin's, right? Incidental discovery of mediastinal mass, chest X-ray. Likely asymptomatic, but could be associated with shortness of breath, cough, retrosternal pain. Again, how many chest X-rays are you guys going to order in your career? A lot. And if you think about just doing physical, doing a flight physical, doing a dive physical, doing whatever, getting a chest X-ray on these dudes, and then something comes back that's not quite right. And it's all good and well when you're sitting stateside, right, and you got a nice radiologist to read stuff for you, as opposed to sometimes you're down read some places and you're the first person looking at that X-ray. I think I see something. All right. Again, excisional biopsy. I gotta get the tissue to go see what this is. I need a biopsy. Immunochemistry is, again, these are just markers on the cell to help identify the cell. Additional workup, yep, CBC, your LDH, PET scan, got it. Yeah, so the Reed-Sternberg cell, that's that creature right here, right? So that's a Reed-Sternberg cell. That's what they say. It looks like the owl eyes. So there it is. That's your Reed-Sternberg cell. Management. All right, everybody, be sure to memorize all those drugs. Don't waste your time. All right, don't do it. But just understand, right? So a bunch of chemotherapy type agents is what they tend to do as. These kidneys. Been assaulted. All right. So again, chemotherapy agents, don't waste your energy trying to memorize those drugs. Relapse disease, stem cell transplant, got it. Prognosis, highly curable for the most part. Another IPS, right? International Prognostic Score. Here, depending on the stage, age, gender, hemoglobin, albumin, WBC. So what are the labs telling you about this patient? So the hemoglobin's telling you what? It's telling you that they're anemic, right? They got a higher than normal white count. The lymphocytes. All right, so again, depending on the risk factors, that'll tell you the cure rate. Hodgkin staging, PET scans, yep, Lugano classification. Here we go. Here's your Lugano again. Stage 1, involvement of a single lymph node. All right, got it. Involvement of 2 or more lymph nodes on the same side of the diaphragm. Stage 2, involvement of lymph nodes either side of the diaphragm. I'm at stage 3, and then additional non-contiguous spread. I'm at stage 4. Your Lugano classification. Here it is in picture form. So here we go. One group of lymph nodes, one side of the diaphragm, got it. Easy, stage 1. There. I got 2 on the same side of the diaphragm, stage 2. I have spread on either side of the diaphragm of stage 3, and now I've gone beyond, right, the lymph nodes into some extranodal involvement areas. I'm at stage 4. So we've gone up. Hodgkin's versus non-Hodgkin's. All right. So what are we dealing with here? B cells, T cells, non-Hodgkin's, right? Don't have Reed-Sternberg, spread non-contiguously and involve extranodal sites. Extranodal, you start to think about non-Hodgkin's. And it can be B cells or T cells, though the majority of the time, which one is it? B cells. So we talk about the condition that affected the GI tract. What is that called? What condition did we talk about affecting the GI tract? MALT. Mucosa-associated lymphoid, right? All right. A little bit of a comparison chart for you here. Non-Hodgkin versus Hodgkin's. Hodgkin's are B cells only. Non-Hodgkin's, take your pick, B cell, T cells. Contiguous versus non-contiguous spread. Again, you can kind of see the different lymph nodes, the different regions, and where is that spread. And then if you want to sort of impose a Lugano classification on this inside of the diaphragms. Yes, huge differential for painless lymphadenopathy. People are going to come to you all the time and they're going to say, hey, I got this big lymph node, I got this thing under my arm, I got this thing in my groin, I got whatever. Right? Every lymphadenopathy is not cancer. But it should be on your differential. But other things should be on your differential also, right? Is it a reactive node? Is it this mono, cat scratch fever? Take your pick. I had this guy with a huge lymphadenopathy, right in his inguinal area. Like, whoa, what's going on? We start looking, and at the end of the day, I had to take his shoe off, and he had this huge, bad, friggin' infection between his toes, right? That it causes lymph nodes in his groin to trigger. Right? Do I have a source for that lymphadenopathy? Can I trace it to something? We didn't just have some sort of viral illness and they have some lymphadenopathy residual to that. Is there something there that I feel comfortable with to say, oh, there's not badness? Just understand all lymphadenopathy isn't necessarily cancer. All right, non-Hodgkin's. Can you figure out, hey, indolent, you mentioned some were more aggressive. Treatment, sure. And then the classic Reed-Sternberg cells, your good old-fashioned ABD, chemotherapy, the need for biopsy, the need for PET scans, the need for imaging. And at the end of the day, if you're suspecting this going on with your patient, what are you doing? You're referring them. So you can initiate that workup, which you should, right? At least get that set of labs, potentially maybe even order that lymph node biopsy, but that patient should be have a consult in the system to go see somebody else, right? Hematology, oncology, somebody else needs to be carrying that patient forward. Questions on the lymphomas?
You mentioned rheumatoid very high yield. What about surface proteins?
Yeah. Don't worry about those surface proteins, right? The CD9, whatever. Just know that does help, right? In terms of differentiating the different cells, and that way they can target treatments, right? But I don't expect you to know the CD9 or whatever, right? But those are markers. Again, to the average lab tech, looking at a slide, a blast is a blast is a blast, and the way to differentiate that is those markers, specialized testing. Flow cytometry, immunochemistry, immunophenotyping. That's all I needed to know about that stuff. Any other questions? Hey, so we mentioned the drugs, not a big deal, right? So yesterday we mentioned the TKI inhibitors. Those are a big deal. Be at least familiar with your TKI inhibitors, right? Because those were game changers. And even if you're not treating these patients, you may come in with a patient you're seeing who is on one. And they're common enough that you should at least be familiar with the TKI inhibitors. What's TKI? Which was the specific one we mentioned yesterday? The JAK2 mutations, right? And we talked about some drugs that target some of those conditions. All right, so hey, we've gotten through a bunch of the lectures pretty quick, right? Please do your homework on this stuff. Figure out what you know and don't know. Come see me, text me, call me, I don't care, right? But we need to get you where you need to get to, because I need all of you gone. I got a bunch of other people waiting to fill these seats. All right? So hey, we need you out of here. Come find me if you need help.
So, is it 2 years?